All right, welcome back. Here we're at another practice question for your Step 2 CK. I am Shell for I am COMAT. Let's go ahead and see the question. Go ahead and pause, answer the question for yourself. We have a 68-year-old man with a history of AFib for which he is on warfarin therapy who presents to the emergency department with sudden onset of severe abdominal pain. He describes the pain as constant and crampy, located in the periumbilical area. It's associated with nausea and vomiting. On exam, his abdomen is tender to palpation. There's no signs of peritonitis. His vital signs include a heart rate of 110, blood pressure of 150/90, respiratory rate 22 per minute, oxygen saturation 98% on room air. Laboratory studies reveal a normal white blood cell count, elevated serum lactate, and an INR within the therapeutic range. And it wants to know what's the best next step. So for this particular question, there's some key points in the history that you want to glean from this question, and they include the AFib, the severe abdominal pain, and then the fairly normal physical exam. Whenever you have a patient who has extreme abdominal pain, but then a benign physical exam, that's going to point you to acute mesenteric ischemia, especially in the history of atrial fibrillation. Because what acute mesenteric ischemia is the patient's not getting enough blood flow to their bowels, and when they become ischemic, it can cause a lot of pain. But because it's acute and just the nature of the condition, you're not going to have any abnormal laboratory signs. And acute mesenteric ischemia is a surgical emergency, and prompt intervention is required. This patient's presentation is concerning for mesenteric ischemia with risk factors including AFib, with a source of potential emboli, because with AFib, you can get clotting that happens in the left atria, and then as it's contracting, it can send it out in the heart, and it can block somewhere, such as the blood flow superior mesenteric artery going to the bowels, small intestine, and that can cause ischemia. Severe abdominal pain, nausea and vomiting, elevated serum lactate, and a therapeutic INR. The periumbilical location of the pain is classic early signs of mesenteric ischemia. So for treatment, going through the answer choices. Answer A, typically contraindicated initially because of the high risk of hemorrhage and uncertainty regarding the presence of arterial or venous thrombosis. Option C, abdominal CT angiography. Although it may be helpful in confirming the diagnosis and identifying the location and extent of mesenteric artery occlusion, it may not be sufficient as a standalone intervention in a patient with high clinical suspicion of acute mesenteric ischemia. Option D, upper endoscopy. It's not indicated for the evaluation of mesenteric ischemia, and it won't really provide anything helpful. And option E, discontinuation of warfarin therapy. It's not appropriate as the patient's INR is already within therapeutic range, and right now the priority is addressing the abdominal pain. And so, as we mentioned before, it's a surgical emergency, so you'd want to put B, emergent exploratory laparotomy. In patients with clinical suspicion of acute mesenteric ischemia, surgical exploration with possible revascularization is often necessary to save ischemic bowel and improve outcomes, because acute mesenteric ischemia carries a high risk of morbidity and mortality. So you really want to get in there quickly to save the patient's bowels and keep them from dying. There you have it. Like and subscribe, comment down below. See you in the next one.